Good afternoon, everyone. Welcome to today's webinar, The Impact of Neonatal Abstinence Syndrome on One West Virginia Community. I am Joe Jones, Senior Vice President at United States Drug Testing Laboratories. United States Drug Testing Laboratories is a specialty reference lab with a 24-year history of newborn forensic toxicology. Presenting today's webinar is Dr. Sean Loudin. Dr. Loudin is a member of the Division of Neonatal-Perinatal Medicine at Marshall University and an Assistant Professor of Pediatrics at the Joan C. School of Medicine. He received his medical degree and completed his pediatric residency at Marshall University and continued his training with a 3-year fellowship in neonatal-perinatal medicine at the Medical University of South Carolina. Dr. Loudin is a board-certified pediatrician, board-certified in neonatology subspecialty, and a member of the American Academy of Pediatrics. If at any time you have a question, please submit it in your question box that you see on the side of your screen. We will do our best to get to as many questions as we can within our hour. And right now, I would like to give the floor to Dr. Sean Loudin to begin today's webinar. Thank you, Dr. Loudin.
Thank you very much. I'd also like to thank everybody at USDTL for allowing me to share our experience here in West Virginia. And hopefully we can all learn and then, ask questions, answer questions, and have some nice discussion at the end of this talk as well, too. So, first, I have no disclosures. What we're going to do today is talk about the epidemiology of NAS, and we're going to talk about it both nationally and regionally. We're going to talk about the mechanism of withdrawal and how the fetus responds to the prenatal exposures to the various substances. We'll talk about the management of the infants with NAS, and then we're going to talk about how we've come up with a sort of system of care here in our region dealing with sort of the epidemic that has occurred. So in Washington, D.C., in about 2010, there was a rather large meeting where the U.S. Department of Health and Human Services released sort of their data on how alarming it was that the rates of NAS had tripled through the decade of the 2000s. It had gone from about 1.2 per thousand live births up to about 3.3, 3.4 per thousand live births. Now, that trend has continued to increase. In a recent article released in the Journal of Perinatology, the incidence has now gone up from about 3.4 to about 6 per thousand live births. Now, one of the things they noted in that study was how there is some wide geographical variation. So what they classify as the East-South Central Division, showed up to about 16 per thousand live births, whereas other areas of the country were very low at even below national rates at 2.6 per thousand live births. Now, this slide just represents where we were at those various time points already as far as the epidemic was concerned. You can see that sort of over that period of time, we've been about 10 times the national average as far as the rates of NAS per thousand live births here at our hospital. And unfortunately, that trend has continued. So in 2013, we had 108 per thousand live births at our hospital affected by NAS. So that's about 11% of all of our deliveries were affected by prenatal substance abuse. Now, frankly, that is a little slightly underestimation of those actual numbers, because we know that there have been some babies who didn't get identified either through OB records, through their biological screenings, and once the babies were born, some of them we know got sent home too early. So some of the substances that can cause withdrawal, and the most popular thing that we think of is the opiates, and that is classically how NAS has been described. But there is an important factor to note that there are other substances that can cause a withdrawal syndrome. And frankly, some of these kind of overlap with the opiate withdrawal that we see in the first few days of life. Nicotine, I think, is the biggest example of that. You know, right after birth, for some of our moms who do smoke a pack or a pack and a half a day, those babies are definitely showing signs of nicotine withdrawal, and at the same time starting to build their opiate withdrawal symptoms as well too. There is actually an alcohol withdrawal syndrome that, you know, that is associated with some irritability in the first few days of life as well. Now, obviously, some of those babies with high consumption can have birth defects that are going to be identified as well. But alcohol is one of those substances where I think we may miss a few of those babies, at least initially. And then there's more of a delayed withdrawal that we consider with some of our other psychotropic medications, benzodiazepines. The withdrawal in those babies may not be seen for 2 to 3 weeks after birth. Some of the SSRIs are, you know, problematic later in life. Not that we necessarily have a lot of options to treat those babies, but it is important to recognize that if a baby is sort of weaning off of their opiate and then at a later date sort of becomes more irritable and they're harder to wean, then that's where some of these substances come into play. So we knew that we sort of had a problem based on our numbers for NAS, but we wanted to look and see just exactly what we were dealing with. We wanted to sort of see where we were at in 2009, and so what one of the maternal fetal medicine specialists did was we tried to collect all the cords at 8 different delivering hospitals across the state of West Virginia. And we did that during 1 month period in August of 2009. We collected a total of 759 umbilical cords, and 19.2% of them were positive for either drugs and or alcohol. Of the positives at that time, 40% of the positives were for marijuana, 28 were for opiates. Interestingly, 27 were positive for alcohol, benzodiazepines, methadone, and we had a little bit of amphetamine use. Interestingly enough, at that point in time, 0% were positive for cocaine and buprenorphine. Now, since that time, buprenorphine is now very prominent in our umbilical cord testing, and partly that is due to the maternal fetal medicine specialist here who did open a buprenorphine clinic, the Maternal Addiction Recovery Center here at Marshall University. So what he does is he does convert those women over to Subutex use and then wean them throughout the pregnancy, or at least maintain them through pregnancy. Methadone is decreasing in frequency while we're seeing that sort of shift in buprenorphine and methadone use. Marijuana still continues to be used at high rates at our institution, at least. Through our second quarter of this year so far, our cords are coming back about 27% positive for marijuana. Prescription opiates are decreasing in their prevalence here. Part of that is, frankly, their availability now. There has been a lot of, obviously, you know, emphasis on decreasing the prescription opiate problem that we have. But along with supply and demand, if that supply is going down, frankly, you know, heroin use now is on the rise. So we are seeing, you know, some shifts in the types of substances that our babies are now exposed to. So what NAS is it all stems from the passive exposure of that newborn when mom is using some type of neuroactive substance during her pregnancy. Obviously what happens at birth is the supply from the mother is cut off because of delivery. Once the placenta and baby are no longer a part of each other, then the substance is no longer being delivered, and basically the baby is cutting cold turkey whatever they were exposed to. Central nervous system signs of irritability, gastrointestinal problems, and then autonomic dysfunction are really the signs and symptoms we see in these babies with NAS. The jitteriness and tremors is really one of the hallmark signs of what neonatal abstinence syndrome can show us about babies. The autonomic overactivity is part of that body regulation, and some of the things that we see in babies who are going through withdrawal that we don't see very often in babies who aren't exposed, or yawning, sneezing, having mottling to their skin, and then temperature instability with fevers being the biggest thing. Also, this cerebral irritation has that irritable and then hypertonic infant. Now, part of what I do actually discuss with a lot of the mothers is actually how they, in using substances prenatally, have really rewired their babies' brains. And I do think this is important for people to understand when we do take care of these babies. And frankly, I want the mothers and caregivers to understand this is taking place as well, because it gives them some perspective on how this process has affected their baby and what we need to do moving forward. So opiates and our own body's opiates are actually important to normal brain development. So there is the interaction between our own endorphins, enkephalins, and dynorphins and to those opiate receptors in the normal developing brain. Now, the locus coeruleus is an important part of this. It's in the brainstem, and it is involved in our response to the stress and panic in response to basically our own body's adrenaline. So opiates are a very good painkiller for one major reason, and that is when opiates bind to a cell, they actually tell that cell to decrease the amount of adrenaline that they make. And frankly, that's why you don't have pain. So that's how an opiate is very effective in killing pain. But the problem is at first it decreases the signal, but the opiate or the adrenaline is still made, and it sort of can increase in time as the fetus is developing. So then at birth, when the opiate is withdrawal, there's no inhibiting that adrenaline release, and so therefore you get a flood of norepinephrine or adrenaline into those, out of those cells, into those brainstem centers and the GI tract and the autonomic nervous system, and then that's what really causes the signs and symptoms of neonatal abstinence syndrome. It is that inappropriate response of the baby to its own body's adrenaline. The way this occurs is two mechanisms. One is called disuse hypersensitivity, and this basically says that, you know, if they're not going to get it through their mechanism to the first pathway, well, they still want to soak up as much adrenaline as they can, so they actually increase the amount of receptors soaking up that adrenaline. This is fine if you have that inhibiting effect, but the problem is as soon as birth sort of occurs and you get that flood of adrenaline, then all of those receptors are then saturated with adrenaline, and this is what causes those striking withdrawal signs. The other is alternative pathways. So again, the brain is smart as it's developing, and it says, well, fine, if I'm not going to get that signal from the adrenaline moving forward, I'm just going to make another pathway around it, so I'll still get that signal of adrenaline. And the problem is then at birth again, when you have the inhibitory factors removed, then you've got a flood of the first pathway as well as the second pathway, and this slide sort of shows that, and I'll sort of use my mouse here. You know, you get an upregulation of receptors on the what's called the postsynaptic nerve, and so therefore all this adrenaline is flooding forward and interacting with all of these receptors. So these are greater number than what used to be there or should be there if the baby wasn't exposed to opiates. And again, what the body does in response is just create new nerve pathways around this inhibitory signal. So how do we identify babies going through withdrawal? Well, the AAP updated their clinical report on neonatal abstinence syndrome in 2012. And they really, you know, sort of say that, you know, obviously we got to use multiple ways. But frankly, maternal history is still one of the most important things. We need to try to get them to tell the truth, to be able to explain, you know, what they were using. It does impact how we treat those babies. Now, also, we can do maternal urine testing, and we can also do biological testing in the newborns with meconium, and then now umbilical cord testing. Urinary excretion, you know, and the very narrow range in which we can have some of those substances be identified is an inhibition to sort of using that exclusively. So it can help us sort of screen for some of these things, but we still need to combine that with the other ways of trying to identify these babies to sort of get the best picture that's available. we can use meconium screening, but now again we do have umbilical cord samples that have some advantages as well too. Now what we use here is the 13-panel USDTL drug screen that has the various substances listed on your screen. You know, the simple fact of the matter is there could be more things that we test, and maybe we need to test because of some of the newer designer drug substances that are out there, and they most certainly have some impact on the developing fetal brain as well. And we do see that once these babies are born. The clinical report also says that, you know, signs of withdrawal should be scored by a published abstinence tool. Now, they don't specify which one we have to use, but, you know, the most popular one across the country is the Finnegan scoring system. You combine the scoring with whatever type of system you use, and then your clinical judgment, and that should, you know, facilitate which babies do get treated, how they get treated, and then it can also help us as we go through the weaning process for these babies and direct that weaning. So this is how the Finnegan scoring system is laid out, and it's broken up into the central nervous system, the autonomic nervous system, and the gastrointestinal system symptoms that we see. Each has numeric values. As the babies have those symptoms at whatever particular assessment they get, you add them up. And the number 8 has been accepted for years as the sign of withdrawal. You score less than 8, most of the time those babies can be dealt with just non-pharmacologic techniques. But if they score an 8 or above, then most people agree that that is at the point at which they do need pharmacologic intervention. Some of the classic symptoms and sort of a screening way of looking at these babies is if you have a baby in the nursery that is exhibiting tremors, it has a very increased tone and has some of those autonomic dysregulations, those are babies that should at least put you know, some red flags up, and that way you should sort of go back and look at the histories and maybe go and talk to the moms, caregivers about whether or not that baby could be at risk for perinatal substance exposure. So how do we treat these babies? Well, there is really no established treatment. Cochrane reviews have suggested some lack of high quality evidence, at least that was back in 2005. We're a decade past that now, and you know, there are tons of new studies out there to look at to see which treatment options we have available to us. Now, you know, expert opinion has suggested that if there are opiate exposures prenatally, then that should sort of be the class of agents that we use to bring them sort of and wean them down postnatally as well too. I'll discuss a few options that we have past that too. Now also in that 2012 report, the AAP did make the statement that the optimal threshold score for beginning therapy is unknown, so it does leave some leeway you know, to different institutions about their own policies regarding at what score you start treatment or what criteria you meet in order to have pharmacotherapy started. But one of the things they do stress is that if there's a baby who, because of, you know, vomiting, diarrhea, dehydration, poor weight gain, and they may not reach that score of 8 or, you know, whatever score may be deemed appropriate, it's an indication in and of itself to go ahead and treat those babies for withdrawal, so that way they don't sort of get behind, and so they can get the nutrition that they need. And then again, they agree that there is limited evidence as to which medication is the preferred treatment. Now here are the options that we have. Morphine is a very, very popular medication around the country to treat these babies who are suffering from NAS. Methadone and then buprenorphine has been shown by Dr. Kraft to be effective and safe to use for these babies as well too. And there are some institutions across the country and in our region even that are doing some studies using that for their babies who are requiring pharmacotherapy. Some of the adjunct agents that can be used are phenobarbital and clonidine. Now, clonidine in some places is actually being used as first-line therapy, and it is, you know, a nice alternative to opiates, because it really does target that norepinephrine or adrenaline release. So that's why it can be used effectively. Now, at our institution, we do use methadone, and we do an inpatient weaning protocol. We use clonidine as our adjunct agent. We have a weight-based, symptom-driven protocol. It is a 9-step weaning protocol. Our average length of stay is around 27 to 29 days. We have a couple different places in the hospital, and I'll talk about that a little bit later, that we are able to utilize for our treatment of these babies. Now, one of the things I enjoyed immensely about that 2012 report from the AAP is that they did stress that non-pharmacologic supportive measures should be the initial approach to these babies. They are different, and they need some different things with environment and handling and things that are important to get them off to the right start even right after birth. In this next section, I will talk about what's called therapeutic handling. It's a very funny picture, but in reality, President Bush is actually kind of doing one of the techniques I'll sort of demonstrate as well too. I do want to sort of say that a lot of this has been adapted from Barbara Drennan's work out in Kent, Washington. So I do need to at least acknowledge that she did work with how to handle these babies. And we've been fortunate enough to be able to talk with her and sort of learn from her techniques. So the first thing is just to reduce the stimuli. So these babies are going to react to light, noise, touch, the things that are going on around them. So they need a little quiet and calm environment. We try to only handle these babies during their feedings, and we try to cluster their care around when they are awake and wanting fed. So that's kind of the first thing that we do. Now the other thing is swaddling. I do actually have a baby here who I'll sort of demonstrate some of these techniques for. And the way we use swaddling is really just to control their bodies. We know that they're going to have some of these tremors, and we try to control their extremities with the swaddling techniques, because as you can imagine, once they sort of break this and one hand gets out, then they sort of fight out of the swaddle, and once one extremity gets going, again, that's a stimuli that then they have to deal with. And then they can sort of just progress throughout their entire body. So we do try to swaddle and use that to control their bodies. The next is the C position. I'll actually sort of unswaddle the baby to demonstrate this now, but really what it is about is bringing the baby sort of knees up and head in a flexed position. We know the babies have some GI irritability, so one of the rationale behind using this is to sort of bring some of that tension up off the baby's knees. So we sort of raise their knees up, head slightly down, and then they sort of look more like in a C position. We use this position in the babies very frequently to calm them down. We hold them in this while we're feeding them, and it really does sort of help to control them and calm them as well. Now, the next is a sway and clap maneuver. Now, I had a colicky baby, and I can remember spending hours and hours just holding the baby and sort of bouncing up and down. Well, a lot of babies like that technique, but some of what we have found is that some of these babies who have been exposed don't really like this particular maneuver. So what the sway and clap is you actually sort of hold the baby in the seat position. You actually kind of rock from side to side as you're holding the baby, and that actually allows more of a head-to-toe motion with the baby rather than sort of an up and down motion. The clap part of it is really just sort of the rhythmic patting of the baby on their bottom as you're sort of swaying from side to side with them. And this can also help to relax the baby as well too. I use sort of the clap sometimes even after I've examined the babies and they're still laying in their cribs to just sort of pat their bottom rhythmically, and they sort of calm down after I'm done messing with them. And then this is actually sort of what I was joking about with President Bush, is something called the vertical rock maneuver. Now, sometimes just having the baby held like this, there actually can sometimes focus on your face. Now, some babies react well to that, but some babies, that just seeing and being able to focus on somebody's face is too overstimulating to them. So one of the techniques that you can do is, while they're still swaddled and held in the C position, you actually turn them away from you, hold them sort of behind the head and under the bottom, and then you can hold them and vertically rock them up and down, again using a head-to-toe motion to help calm them down. But as they're faced away, they're not really able to focus on faces or things, and so they're not getting that overstimulation from that visual stimulation. And then feeding is sort of the last thing. Again, we want to feed them in a calm, quiet environment. We don't want to hold on a big party while we're trying to feed babies. We keep them in the C position. And again, a lot of times we use the middle finger under their chin to sort of support their mouth as we hold the bottle in, because they may not be the most efficient feeders ever as well too. So those are some of the techniques. We do train our volunteers, our volunteer cuddlers, all of our nurses, our PCAs, all of them are trained on these therapeutic handling techniques. The next section that I'd like to talk about is sort of just the system of care that we've used to approach these babies here in our area. Now, a lot of this came from just the fact that our NICU was overcrowded. If you looked at some of our statistics from 2011, there were times where we'd have a total NICU census of 28 babies, and we'd have 14 to 17 of them affected by NAS. So anywhere from 50 to 2/3 of our unit were just NAS babies. And so we had to try to come up with something different to use. We wanted those beds in the NICU available for sick, preterm sick babies that needed NICU care, and we didn't want to have to turn those babies away because we had sort of an overcrowding of babies who were going through withdrawal. So we wanted to try to figure out how we could improve our system of care. And the folks at Pediatrics have recently sort of looked at the data from their hospitals over a 10-year period, and again, their evidence is striking. So in 2004, they had 7 cases of NAS per 1,000 NICU admissions. Now that's not live births, that is just their NICU admissions, and that increased up to 27 cases per 1,000 NICU admissions. Their length of stay for these babies has increased over that period of time. So you went from 13 days to 19 days. Also, just the total percentage of days has gone up as well too, from less than 1% to 4% of all their NICU days. And then again, those babies needing pharmacotherapy. So we have to do something. So here we're able to use 3 different places to take care of these babies, and each of them serves a different role. So the NICU really, when you look at it, it is probably not the best environment for these babies to be in. From a pure just environmental standpoint. Obviously they're going to get great care, but it's some of the other things that we want to think about. In this isolette, you take care of sick babies. You've got a lot of light in the room. You've got the monitors. You've got the bells and whistles. You've got the high activity of other sick babies being around those babies even. So that environment, while it is great for our tiniest preemies, and we need that environment for these babies, it may not be the best place once you sort of get everything figured out. Make sure that there are no other medical problems wrong with this baby that makes them sort of sicker than just going through withdrawal. But it may not be completely appropriate from an environmental standpoint for those babies. So we actually do have another unit in our hospital, which we call the Neonatal Therapeutic Unit. It is a locked unit. It is controlled by our unit clerk. They control the visitors who come in and out of there. As you can see from this picture, even our hallways are dark. We don't have a lot of activity in there. We remind people that it is a quiet zone in the hospital. We have 5 rooms available to us, and we have 3 to 4 beds per room. We do have some restricted visitation hours. Now, again, a lot of it is about whether or not we're trying to punish these moms, and the simple fact of the matter is we're not. What we're trying to do with those limited visitation hours is to really control the stimulation of those babies. Frankly, when they go home, the daytime is going to be the most stimulating time for them. So we want them to be stimulated during sort of those peak daytime hours. We want them to get used to that. However, what we don't want is a lot of sort of overstimulation at nighttime. We want them to be able to rest and sleep and feed and everything during the nighttime hours. So it is why that that we have those policies. This is a picture of inside one of our rooms there. We keep dim light. We try to just use the natural light from the window and maybe one additional light in the room to keep it a little bit dark and quiet. An additional fortunate thing that we have in our community is a place called Lily's Place, and we just have been recently able to open our doors and accept babies to there as well. Now, what Lily's Place is, it is a nonprofit 501c3 organization. The good thing about it is we have had community support from day one as we've been opening Lily's Place. We wouldn't be able to have babies in there today if it weren't for all of what the community has done for Lily's Place and for this patient population. We were very fortunate to have the building completely donated to our cause. It used to actually be a pediatrist's office here in our community. And the widow of that pediatrist found out about Lily's Place and just basically gave us the building. We renovated it, but frankly, it was already set up. You know, numerous private rooms, nurses' stations. It was the perfect building for a place like this. And then every nursery, and you'll see some pictures of these nurseries, they were sponsored by either churches or individuals or families who then came in, painted it, furnished it, and made it really look like anybody's room at home. We obviously had to do our due diligence to bring the building up to life safety code, and which we have, and meets all the West Virginia State code for those things. Now, part of what we have run into is just because this is such a sort of a new thing, has been sort of how we are licensed in that whole process. For instance, the West Virginia Department of Health and Human Resources, they classify us as a group residential pediatric addiction recovery facility. The DEA actually classifies us as a hospital/clinic, and then the city of Huntington actually calls us a nursing home. Now, on top of that, the IRS calls us a hospital, and West Virginia Medicaid calls us a mental health facility. So we do have a bit of identity crisis just because of how new this is and trying to sort of fit this into some of the state regulations, frankly, as well as national regulations that exist. Now, a big step in the right direction was actually West Virginia House Bill 2999, which just recently passed through the legislature of West Virginia and basically has created a new healthcare facility designation of a NAS center. It is still going through the sort of vetting process of that bill and coming up with the policies and procedures to make this facility run, as well as open up the capacity and pipeline for other places like Lily's Place to open up in our state, in places that can handle its use and that need it based on their population as well too. These are just some examples of the nurseries that we have at Lily's Place, and one of the nice things is if you do walk through the doors and each baby really has their own room, it is like you're walking into somebody's house, and that's really the point of this. Is we want babies to be able to get used to that final transition to home, so we can utilize the NICU, utilize the NTU at the hospital, and then utilize Lily's Place to try to stepwise, come up with a way of transitioning these babies from acute withdrawal, get them settled out from a medication standpoint, and then really transition them to be able to go home and out into society. One of the nice things that we also have at Lily's Place is at least a room that allows us to have parents room in. So if those parents, aren't displaying sort of all the characteristics and behaviors we want them to know that we're comfortable sending them home, we can actually have the parents stay the night. Their baby can be in the room with them, and they can basically practice parenting, so that way we can all feel comfortable that they know what they're doing whenever they're taking these infants home. So part of some of the future directions that obviously we would like to go is the state and us have a big focus on, we want to be able to increase the access to resources for adults. We have to try to stem the tide of substance abuse in the adult population. If we can obviously, have moms recognize that using drugs is not sort of the best option for them and their baby, we need to have those, services available. We need to talk about, the consequences of substance abuse with various populations. And the younger we do it, the probably better off we will start making some impact. We need to try to come up with innovative ways to treat patients of all ages. We do have some babies who are going through withdrawal, who have been exposed to a lot of polypharmacy, who are older than what we typically think of for those babies going through acute withdrawal. So how do we adapt the way that we treat those babies is important. And then obviously, we're working hard to just continue to expand research in the field of NAS. So at this time, I want to thank you for the presentation, and then obviously be able to open it up to questions.
Thank you, Dr. Loudin. We did have a few questions come in. The first question that I have is, it's a little bit of a lengthy one, so I'll break it up into two parts. Do you use the Finnegan scoring tool for babies at risk for NAS based on maternal history, or only those infants with a positive toxicology or signs and symptoms of NAS?
Yes, we use it for maternal history as well too, and frankly, we even use it for babies who maybe we don't get a good maternal history for, but if we, as some of the nurses, notice some of these hallmark symptoms like tremor or tone or some of these autonomic things, we'll then sort of begin scoring them with the entire Finnegan scoring system, even if we don't have any positive maternal history or biological specimens at the time. And frankly, then it becomes having conversations with those parents about, this is what I'm seeing, and this is one of the reasons why we see this in babies. So then we sort of have more of a heart-to-heart conversation, and sometimes we get to the truth, and sometimes we don't.
Great, thank you. And then the second part to that question is, do you score the infants whose mothers have used marijuana and cocaine, or only opioids, non-opioids, as listed in the AAP recommendations for NAS management?
So the way we approach marijuana and cocaine is that if we have a mom who, because we do universal maternal drug screen at the time of delivery. If we were to have one of those that only comes back positive for marijuana or cocaine, we observe those infants and we will score those infants. If at the time of 48 hours, 72 hours, whenever the mom is being able to be discharged based on sort of whether or not she was vaginal or C-section or whatever, if those babies are scoring very, very low on the Finnegan scoring system, then that's at least partially reassuring that there may not have been other substances that they have been exposed to, prenatally. Now, we still do try to send all the cords on babies who are positive for marijuana and cocaine as well too. And so if they score low, then we do send them home at the time that they're ready to be discharged. If they're having borderline scores in that 7 or 8 range, then we will continue to observe those babies for 5 to 7 days, like the AAP does recommend for opiates, just to try to watch them to see if they are going to exhibit some delayed withdrawal symptoms.
Thanks, Dr. Loudin. We have another question. Are universal drug screenings done on all mothers at their hospital at Cabell Huntington, or is this a state of West Virginia policy?
So it is not state of West Virginia policy. However, there are, I would say, about 50-50 split around the delivery hospitals across the state as to universal screening for the moms whenever they do deliver. Yes, so we have a universal screening policy here at Cabell that all moms who come in to deliver a baby prior to delivery are getting a urine drug screen.
In addition to that, do you use the umbilical cord testing for all deliveries or with those that meet specific criteria? If so, what's the criteria?
So unfortunately, we don't use it for all of our deliveries yet. We're in the process of sort of looking at whether or not we will make that policy here at our institution. So we do send, we try to save every cord that we have for all babies who are born. Now, obviously that depends on whether or not the obstetrician gives us enough cord. So, it does take very good communication between the pediatric side of things and the OB side of things to make sure that everybody is on the same page, because without the obstetricians, doing, what we suggest that they do, we're still going to be left with not a way to confirm via biological specimens with the umbilical cord. We can still send meconium as well, but again, it sort of takes a little bit longer sometimes for the meconium to come back. So we don't send it all, but what we do, how we approach it is, if there is a positive urine drug screen for a mom, then we will send that cord. And again, or if they do have a history in this pregnancy of maternal substance abuse that they admit to, then we will send those cords. So in order to have a cord sent here, it is either a positive urine drug screen for any substance, marijuana included. We will send those cords for confirmation, as well as if we have a mother who, through the history and physical process from the obstetrician standpoint, is identified as using substances during her pregnancy, and we will send those cords for confirmation as well.
Thanks, Dr. Loudin. We had another question. What is your NAS length of stay?
So right now, it is about 27 to 29 days. Now, obviously we have some babies that get out sooner than that, and frankly, some babies who are staying a lot longer than that. Frankly, our record holder right now is we've had a baby in our care for 100 days because of massive polysubstance abuse, basically using everything you can imagine, plus the abuse of Neurontin, which is now increasing in its incidence, especially in our area.
Next question we had come through is, what is the turnaround time for your cord drug testing?
Well, we're very fortunate that some of our cords can sort of come back and report in 3 days. It's usually about a 3 to 5 day turnaround for our results. So most of the time, as we're sort of approaching that 5 to 7 day observation period that the AAP recommends, we are getting our confirmation back on those babies.
Great. The next question is, are babies at Lily's place on medications?
Yes, they are. That was part of the process of really getting everything, our I's dotted and T's crossed with all the agencies we need to, and one of them was the DEA. So we had to be approved by them to be able to dispense medication. We also have gone through the West Virginia Board of Pharmacy to make sure that we were doing all of the right things to be able to dispense medications to those babies. So the answer is yes. If you basically took all of the care that we do in the hospital, we're doing the same exact care at Lily's place. So they can be treated with all the medications that we need to treat them just like you would in the hospital.
Thank you. Next question is, have your results been used in court? What's your experience with this new sample type within the legal setting?
It varies. So, we live in a tri-state area. So in West Virginia, we don't necessarily have any of the repercussions that some states like Tennessee are now experiencing as far as prenatal exposure and then sort of the legal aspects of the system. Now, Ohio does have some sort of certain laws that will actually, based on prenatal exposure, sort of remove those babies from custody. Not in every single case, but in some cases. So I have been, brought in as a witness to some court cases as well. And frankly, it really is about, from a medical standpoint, showing that yes, this baby truly was affected either by the biological samples or the scoring and clinical aspect of things, to at least prove to the court system, and frankly, so there's no sort of ifs, ands, or buts or questions about that. Yes, this baby was prenatally exposed. Yes, we had to treat it. Yes, it was affected. And then, you know, that becomes less of sort of a leg to stand on from a parental standpoint, trying to get custody back from these babies. You know, frankly, in the few times that I've been called in as an expert witness, I really haven't had to say anything because the results are there. That says, yes, this baby was exposed. It did show these symptoms, and we had to treat it. So then that's at least the first acknowledgement, you know, from both parties, prosecution and you know, the caregivers, parents, to say, okay, yes, this happened. Now we'll move on and go through the other aspects of the legal system for that. So that's sort of how I guess I get not used, but you know, utilized in the court system.
Great, thank you. Next question is, can a mother's urine screen be negative and the infant's cord test come back as a positive?
Yes, absolutely. And it happens frequently. You know, for a couple different reasons. And again, the metabolism of drugs, you know, can be very, very fast. So we may not pick everything up in the urine. However, when you think about what the cord testing is you're really not testing the cord, the cord blood, you're testing the cord tissue. The way I explain it to a lot of our med students and residents, and frankly even the parents too, is that the way I like to look at it is the cord is a tree, and sort of, you know, the rings of a tree sort of tell the life of that tree. And so the substances get distributed throughout the tissue of the cord itself. And those metabolites can stay in there in that orange jelly and the substances that's in the substance inside the cord. So that's actually what is used in the cord samples. So it does retain those substances and their metabolites for a longer period of time, you know, going back to basically half of the pregnancy, if not a little longer than that. So there is some variation in how long the cords will look back at, and again, that depends on the metabolism. Each mom, each baby, they have their own metabolism for a variety of substances. So that's why, you know, no sample is ever going to be perfect. Urine, meconium, you know, umbilical cord, is because people, human beings, metabolize drugs in so different ways.
Thanks, Dr. Loudin. We're going to take about 3 or 4 more questions. Next question is, what is your nurse to patient ratio for infants with NAS?
So right now we have 1 nurse for every 3 patients, and we feel like that is, you know, an appropriate ratio. It allows the nurses to do their assessments, to be able to feed the babies, to be able to frankly take care of their symptoms, to be able to do the therapeutic handling techniques efficiently, effectively, and I guess efficiently as well too, whenever you have 2 other babies. The other thing that we really try to utilize too is our patient care assistants, so our PCAs and volunteer cuddlers during the daytime as well too. We utilize all of those folks to really take care of these babies. Because, you know, unfortunately, 1 nurse may have 3 of the worst babies in the unit, just because that's the room that is, you know, kind of having a bad day. And so it's important to have people who can help, because we don't want, you know, the 1 baby that she's, you know, helping at the time, and the 2 others are standing there, you know, laying there and just kind of completely having fits. The longer they go, the more they get worked up, the more stimuli they respond to, and so it's a very vicious cycle. So we want to be able to have people be able to come in, respond to their needs, and sort of be able to use some of these techniques to calm them down.
Thank you. The next question is, what are you using to treat Neurontin use?
Well, stay tuned for a paper that will be coming out in a not so distant future. We're going to be describing sort of our experiences with Neurontin and how we're dealing with these babies. I can tell you we're being sort of very aggressive with their you know, methadone use and frankly our adjunct therapy with clonidine as well in the initial phases, because the vast majority, all of these babies who we've encountered who have been on Neurontin have also been on opiates. That's why the moms are using Neurontin, is because when you use Neurontin and opiates at the same time, then you have to use less opiate to actually get the same high, or if you're using Neurontin and an opiate and use the same dose, you actually get higher. So the Neurontin potentiates the opiate. So you know, we're in the process of getting that information out to the rest of the medical community, and our observations and our experiences will be out there very soon.
Great, thank you. We're going to take two more. A recent webinar presenting data from the Cincinnati Perinatal Institute and Ohio Children's Hospital claimed infant treatment length of 19 days with an overall length of stay of 22 days. Do you have any future recommendations to shorten the length of stay?
Well, you know, unfortunately, and this is sort of my take on you know, NAS treatment, is you have to do what's right for your population. You know, I think there's maybe some push to try to get everybody on the same page about how to treat these babies. To me, I'm not one of those folks who believes that. I truly believe that your population and your community really does impact how you treat these babies. And it frankly may be different than a community very close to you. So, you know, you know, our length of stay is a little bit longer than, you know, than even Cincinnati's. But again, our rates of polysubstance abuse are astronomically high compared to other areas of the country. So I do think all of those impact your length of stay. Now, the other thing that I'm a big proponent of, and hospital, you know, sort of CEOs may not necessarily follow this, you know, train of thought either, is I don't think the emphasis should be on how long a baby is in the hospital as opposed to getting this baby safe to go home. Yes, we want the babies out of the hospital, but I also don't want to let them go early. I want them to be safe. I want them to be able to manage themselves and manage their ability to deal with the environment by the time they go home. If they go home early and the parents aren't ready for that, then we're going to have, you know, shaken baby syndrome at an astronomical rate too. So there's a fine balance between trying to reduce length of stay and what's safest for the babies. You know, we view our job as an advocate for this baby. The moms get to talk. The moms get to, you know, to say, you know, this is what we need. Adults are the decision makers, but we here with myself and Sarah Murray and Rhonda Edmonds, who are you know, the team beside me, even though they're not here beside me, but they are with me. We have really taken this on as far as to advocate for the babies.
Thank you, Dr. Loudin. And one more question for today. Are mothers with positives for marijuana allowed to breastfeed?
No, and that's, you know, AAP recommendations as well. You know, the AAP does, you know, recommend that breastfeeding or marijuana is a contraindication to breastfeeding. So no, those moms are not allowed to breastfeed. At least while they're under our care. I can't hold their hand when they go home, but we make it very clear to them that, you know, that there are long-term neurodevelopmental consequences from their prenatal exposure to marijuana, as well as what could be, you know, the continued exposure through their breast milk.
Great. Thanks, Dr. Loudin. And that is all the time that we have for today. If we did not get to your question, we will make sure to reach out to you after the presentation. But I want to say a big thanks to Dr. Loudin and also to all of you that are attending. We apologize again for that technical difficulty and delay, but sometimes things happen. But thank you